بسم الله الرحمن الرحيم. رب اشرح لي صدري ويسر لي أمري واحلل عقدة من لساني يفقهوا قولي. Today's discussion is about how to keep cirrhotic patients alive. When we diagnose a patient with cirrhosis, we are going to accept a big challenge. And not only one challenge, rather so many sub-challenges ahead. So diagnosing a patient with cirrhosis means facing so many challenges. The target audience for my today's lecture is medical students, postgraduates, primary care physicians, and internists. So the consultants in gastroenterology will be having some content in it, but most of the content is for medical students, postgraduate students, primary care physicians, and internists. And the learning objectives of my talk is that at the end of the lecture, you will be able to understand the natural history of cirrhosis liver. You'll be able to monitor cirrhotic patients over time, to differentiate different stages of cirrhosis, to prevent decompensation to happen, to identify decompensation promptly, and to link with liver transplant options. So I will try to give an overview of all these aspects in my allocated time. We all know that a liver is a very special organ in the body with its specific anatomy and physiology. And for the normal functioning of the liver, the anatomy should be normal and physiology should be normal. The viral diseases like hepatitis B, hepatitis C, hepatitis D, the non-viral diseases like alcoholic liver disease, autoimmune liver disease, primary biliary cirrhosis, Wilson's disease, hemochromatosis, all these, when they affect the liver, they cause acute inflammation, and if the inflammation is not restored within 6 months, the chronic inflammatory phase starts. And we all know that chronic inflammation is associated with fibrosis. And when the fibrosis reaches its maximum, the regenerative nodules appears, and the F4 fibrosis with regenerate nodules is equal to liver cirrhosis. So the liver cirrhosis is characterized by altered anatomy and loss of functions of the liver. We all know that the liver cirrhosis is a lifelong disease, just like diabetes and hypertension. It's gradually worsening. It is associated with complications, and it's a lethal one. If you don't intervene, you will lose the patients. How to diagnose? We all know the clinical features when a patient has developed the clinical features like ascites, like spider nevi, like palmar erythemas, and others. It's very easy to diagnose that my patient has got liver cirrhosis. In the absence of the clinical features, then the ultrasound and labs can help us to diagnose that the patient has got the liver cirrhosis. In the ultrasound, we all know in well-established cirrhosis, liver is small, shrunken, dilated portal veins, splenomegaly, and with or without ascites. Even if there is no clinical features and the ultrasound is normal, then the FIB4, APRI, and the fibroscans, with the help of these, you can find out whether my patient has developed cirrhosis or not. And in the long term, we know this is a CTP score and MEL score clinically, which are used to monitor the progress of these cirrhotic patients. The mainstay or the main problem is the so many complications of the liver cirrhotic patients. The topmost, if you start from the above, is the hepatic encephalopathy, which is a well-known complications. The second complication is the variceal bleed. Patient bleeds from the esophageal varices, from the gastric varices, from the portal hypertensive gastropathy. Ascites is another, rather the most common complications, and very soon the ascites may not be a simple ascites, it may progress into refractory ascites. Uh, the patient may go into hepatorenal syndrome, it may get infected, and mind it that the SBP is the well-known complication of this is the hepatorenal syndrome. Another complications of these patients is the development of the hepatocellular carcinomas. Infections, they've got very low immunity, these patients, and they are prone to develop different sorts of infections. The coagulopathy, this is another complications of cirrhotic patients, which may cause problems in doing even different procedures. And the malnutrition, which is unfortunately the missed one in most of the patients, but this is the, rather, if I say this is the most common complication, I will not be wrong. And then on top of that, even the patient may not have developed these complications. These patients may develop acute and chronic liver failure, and they will deteriorate very suddenly. We all know that if a patient has got recurrent hepatic encephalopathy, the patient has got refractory variceal bleed, if patient has got refractory ascites or hepatorenal syndrome, or if the patient has got hepatocellular carcinoma, which is within the range of the surgery or cure, or if the patient has got developed acute and chronic liver failure, all these then do need liver transplant. So liver transplant is the ultimate solution for most of these patients. But liver transplant is not a simple procedure. It's option of treatment which is associated with lifelong requirements of immunosuppressive drugs. There's a disease reactivation in these patients and drug-drug interactions because the patients use immunosuppressant drugs lifelong. And if the patient has got other comorbid condition like diabetes, hypertension, coronary artery disease, then the drug-drug interactions is really an issue in these patients. So to keep the patients away from the liver transplants and to keep the patients clinically stable, the concepts of the primary prevention, the event treatment, and the secondary prevention is there. For all these complications, the aim is once you diagnose a patient to be having liver cirrhosis, we should try to prevent these complications to happen even at the start. And if the patient presents with these complications as an acute deterioration like acute hepatic encephalopathy or acute variceal bleed or huge ascites, then of course care of these patients. If the patient presents to you with a hepatocellular carcinoma, depending upon the stage, then from care to palliative treatment may be offered. And once you successfully treat these patients, the acute presentation, then a concept of the secondary prevention comes, and there are secondary preventive protocols for hepatic encephalopathy, for variceal bleed, for ascites, surveillance for tumor, and for the good nutrition. So the whole picture is full of challenges, complications, and proper treatment and proper interventions. So the aim is once you diagnose a patient with liver cirrhosis, you need to implement these primary preventive measures. If the patient is presented with some acute deterioration, then the even management of that complications, and after successful treating that complications, to go for the secondary preventive measures, depending upon which complications you deal with. Another concept which I would like to get your attention on, that the cirrhotic patient has three main stages. One is the compensated cirrhotic stage, which extends for 10 to 12 years. Then the decompensated cirrhotic stage, where the lifespan is on average 2 years, and the terminal stage when the life is less than 2 months. And when we see these complications, the hepatic encephalopathy, the variceal bleed, the ascites, the hepatocellular carcinoma, and the ACLF, as we go from the compensated cirrhosis to the decompensated cirrhosis, the prevalence of the prevalence of these complications, it increases. The chances of patient developing these complications increases, and the severity of these complications increases. So if your patient at the start is in compensated cirrhosis, look for these complications. They may not be clinically evident, but they may develop. But if the patient has got decompensated cirrhosis, do actively exclude these complications if they have happened. So this is one concept. Another concept is the relationship between the liver cirrhosis and the liver transplant. There are two ways. One is the slow decompensation, which is the natural decompensation phase of the cirrhotic patients, that over 10 to 12 years, they decompensate and they may need liver transplant. Another is the fast track. Then these patients, they don't wait for 10, 12 years, they need liver transplant earlier one. And who are these patients? One is those who develop hepatocellular carcinoma, and if it is within the resection stage Milan criteria, less than 5 centimeters solitary lesion, or 3 lesions, and none of these more than 3 centimeter, or if the patient develops acute and chronic liver failure, then here this becomes the fast track that they may need liver transplant earlier on at the early stage of the patient becoming cirrhotic. So with these concepts keeping in mind, how to monitor cirrhotic patients? As I said before, the CTP score and the MELD and MELD plus score, these are the clinical scores which help us to monitor these patients as we monitor hypertension, diabetes, with the clinically parameters as well as with the blood parameters. Similarly here, the CTP score and MELD scoring, they are very good clinically useful parameters which monitor these patients. We all know the CTP score has got the 5 components: encephalopathy, ascites, bilirubin, albumin, prothrombin time, and depending upon the severity, 1 to 3 points are given. For juniors, remember the CTP score by the words A, B, C, D. A means for the albumin level, B means for the bilirubin, C means for the clotting or the prothrombin time, D means for the distension of the abdomen or ascites, and E means for the encephalopathy. And depending upon the score, the patient may be in child class A, where the score is 5 or 6, or if it is more than that, 10 or more than that, patient is really worse. It is a decompensated, and the B is the decompensated. And this is very, very important, because if you are able, or if your patient in child class A, 100% survival at the end of the 1 year, and 2 year survival is 85%. But if the patient is in child class C at the first visit, 1 year survival is 45%, and 2 year survival is 35% or less. So this is a very useful clinical parameters, very easy one, and please use these in your clinical management of these patients. Another is the MELD score. Again, the smartphone-based parameters, these are done, and the creatinine and the bilirubin levels, and they tell you really the 3 months observed mortality. If the score is less than 15, it's a good one. Less than 10 is really ideal one, but as the score goes on, the mortality is really very, very high. Then another concept is the hepatic venous pressure gradient. We don't measure this patient, these parameters clinically, but the concept should be, if the patient's in 1 to 5, it's a normal portal hypertension, portal pressure. 6 to 10 is the preclinical sinusoidal portal hypertension. 10 or more than 10 is called clinically significant portal hypertension. More than 12 is increased risk for rupture of the varices. And if it is more than 16, it's increased risk of mortality. And more than 20 is this, the treatment failure will be there, and we'll be unable to control these patients. This is the very important. I need your attention for 30 seconds here. If your patient is in child class A, the MELD, by and large, the MELD is 10 or less than 10, and the hepatic venous pressure gradient is less than 12. So if you are able to keep your patient in child class A, this will be the underlying pathophysiological pressures. But in child class C, you see the MELD is high, and the hepatic venous pressure gradient is more than 20 to 22 in these patients. So it means the therapeutic interventions will not be that much effective. So the aim is to keep our patient in child class A, and how we keep our patient in child class A to take care of their nutrition, good albumin, the PT synthetic activity, the bilirubin should be normalized. There should be no ascites. The patient should be prevented from against the hepatic encephalopathy. And if the patient has got no encephalopathy, patient has got no ascites, albumin level is okay, PT is normal, and the bilirubin is okay, then your patient is in child class A, and it's a very good candidate. It's a very good patient of cirrhosis. So I'll be share with you briefly the real world experience in Pakistan. We published our data in 2016, 6 years ago in Tokyo Apazal, where we presented the our center cirrhotics data. It was a descriptive study. The 77% of the patients, which was more than 2,000, they were because of HCV, and 600 patients, which comes 22%, these were because of the hepatitis B, and only 1% were because of the other reasons. And the good point is that at the time of presentation, more than half of the patients, they were in child class A, and then another 36%, they were in child class B, and 11% were in child class C. And similarly, the almost half of them, the MELD score was less than 10. Point is, and when patient present to you with liver cirrhosis, it's not necessary that they will be in advanced stages. They present to you, half of them, they present to you with early or in the compensated stage, and then it's your way how to monitor these patients and how to take care of these complications, how to prevent, offer the primary prophylactic measures and prevent them to develop variceal bleed, to develop the ascites, to develop the encephalopathy, and good nutrition. And if you do that, probably you will be able to help more than 50% of your patients in a good way. And this is the complications profile of our patients. The most common was ascites, 44%, followed by the overt encephalopathy, then varices, variceal bleed, 11%, coagulopathy, 22%. 12% of these patients at the time of presentation, 312, they were having space occupying lesion, they were having hepatoma. So hepatoma is not uncommon, and this is 2016 data, and know what my colleagues will agree with me that no, the prevalence or the finding of the hepatocellular carcinoma is really very, very high. So the treatment, with all keeping all these concepts in mind, the first treatment is if you diagnose a patient with liver cirrhosis, your aim should be to arrest the inflammation and treat the etiology if you can. If the patient is B PCR positive, C PCR positive, or other active diseases, treat that etiology. Even with the just positive PCR, or even with the negative PCR of hepatitis B, you will give the antiviral treatment. The second aim is then to keep your patients in child class A. And then how you will keep this patient in child class A? By taking care of good nutrition and taking care of the ascites and encephalopathy, the bilirubin and PTINR, and your patients will be in child class A, because if a patient is in child class A, it's a very good prognosis and very less morbidity. The third way or component or aspect is treat acute conditions. If a patient is presented to you with acute hepatic encephalopathy, acute variceal bleed, or ascites, then are acute infections, then treat these conditions. The fourth component, that for each and every patient deserve the primary and secondary prophylactic strategies, and you should be clear that to which complications which strategy is available. This is very, very important. Ensure desirable nutritional status, because as I said, this is the most ignored part of the management of cirrhotic patients, so please give special attention to this. The sixth one is prompt and effective control of infections. Your threshold for diagnosing infection should be very, very low. If you suspect, treat that patients with good antibiotics, standard antibiotics, because they who got very low immunity and the infections really becomes out of control very soon. Avoidance of the hepatotoxic drugs. This is very important that patient should avoid unnecessary drugs in these patients. And the eighth is surveillance for hepatocellular carcinoma. With all these 8 aspects keeping in mind, please never forget to vaccinate uh, uh, against hepatitis B if the patient is etiology is more other than hepatitis B in all patients with hepatitis E virus vaccine. This is very, very important because our aim is to prevent the decompensation in these very patients. As I said, the liver transplant is the ultimate therapeutic options in these patients, but the post-liver transplant lifelong care is required in terms of the immunosuppressor drugs, the disease reactivation is there, drug-drug interaction is there, so we should be very, very careful. So, dear colleagues, this is the last couple of slides. Now I'll share with you that what should be the do's and don'ts of these patients to try to keep the cirrhotic patients alive. And I have divided these into 3 ways: in the indoor, in the outdoor, and in the home. If you admitted a patient in the indoor, then please don't ignore these 4 aspects. One is the patients. If a patient is presented with ascites, if your patient has developed spontaneous bacterial peritonitis and you admitted the patient for that, if you admitted the patient with suspected variceal bleeding, or if you admitted the patient with hepatic encephalopathy, these are the 4 complications for which we admit a patient. If you admitted a patient with ascites, please do perform a diagnostic paracentesis on admission. Don't delay the procedure for coagulopathy, transfuse blood products prior to procedure. So please, this is very, very important. They do perform a diagnostic paracentesis. You admitted a patient for ascites with you. Second, if you have diagnosed the patient with spontaneous bacterial peritonitis, then start antibiotic quickly and give albumin on day 1 and day 3. This is very, very important. And do not forget to prescribe long-term antibiotics for secondary prophylaxis when you discharge them. In case of suspected variceal bleeding, perform endoscopy and start medical therapy with active drugs and antibiotics quickly as soon as possible after stabilization of these patients. And do not forget secondary prophylaxis. This is very important. Once you start these patients from your ward, the non-selective beta blockers and follow-up endoscopies are very, very important. And if you admitted a patient with hepatic encephalopathy, please do look for precipitating factors. And most of them, you will get precipitating factors like constipations, like bleed, like infections, like SBPs, and treat that. And please do not forget to prescribe lifelong lactulose with or without rifaximin. But what I do that I put them on lactulose lifelong and rifaximin for at least 6 months. This is the do's and don'ts in case of indoor patients. What about the outdoor patient? When you are sitting in a clinic and outdoor and the patient comes to you, again, do's and don'ts. The first 3 important is the disease status and referral. For disease status, please inquire about hepatic encephalopathy, variceal bleed, ascites since last visit with you, and do not presume that patients will report these by himself or herself. You have to ask. Then for disease status, calculate CTP score, MELD score, and do weigh the body weight. And do not presume that patients may be compliant with prophylactic medications. You may have given the patient prophylactic measures, drugs, but the patient may not be using it. So please, this is very, very important. And take opinion of relevant colleagues. Please do not consider yourself as master of all. Care, the best care of cirrhotic patient is the MD team care, not only for the HCC, rather for the whole cirrhotic as a disease. The other do and don'ts is an outdoor is the ascites management, occult hepatic encephalopathy, and hepatocellular carcinoma. For ascites management, please do instruct patients on self-management salt restriction, weight recording, and red flags. The patient must be knowing that what are the red flags in ascites and what is the importance of the weight maintenance and avoiding the extra salt. Please do not wait until ascites becomes unbearable, necessitating emergency room or hospital admission. So this is very important. You should be preemptive rather than reactive. For hepatic encephalopathy, please look for the occult hepatic encephalopathy on every visit when a patient comes to you. And please do not prescribe sleeping pills for insomnia. What happens that especially in primary care physician setups, the patients, they've got reversal of the sleep, they don't sleep, and they are prescribed the sleeping pill. This is criminal act in these patients, and they push the patients from minimal encephalopathy to the from the occult encephalopathy into the overt hepatic encephalopathy. And hepatocellular carcinoma, please do screen with ultrasound and serum alpha fetoprotein every 6 months. And please do not leave patients out of screening. Lifelong, they should be in the screening protocol. Other important parameters, variables is the health maintenance, pain management, nutrition, and quality of life. For the health maintenance, please assess vaccination status and general health maintenance issues, the cardiovascular disease and smoking cessation. Please do not leave all health maintenance up to the patient's primary care providers. If you are at the a bit at secondary level, or even if you are very good busy primary care provider, please do ensure that health maintenance is taken care of. For pain management, discuss the safety of limited 2 gram per day acetaminophen use. They should not be using it freely, and please do not prescribe NSAIDs to these patients. For nutrition, recognize the malnutrition and refer to dietitians early if they are available. Otherwise, you have to give the extra time. And please do not restrict protein in these patients. This is a very, very common mistake which is done in our society. For quality of life, please discuss common disabling symptoms in cirrhosis, the muscle cramps, the pruritus, the sleep disturbances, and sexual dysfunction. And please do not wait for the patient to bring the issues up. You have to ask. For these common symptoms like muscle cramps, please do ask that how often during the last 2 weeks have you had muscle cramps. This is very, very important. You ask from them. If the cramps are there, you normalize the electrolytes, the fluid balance. They may be because of electrolyte fluid imbalance because of the diuretics, taurine, vitamin E, and baclofen have been tried in these patients. For pruritus, again, you must ask how much of the time you have been troubled by itching during last 2 weeks. This is very important. You should ask, and if there is pruritus, options are available, moisturizing creams, cholestyramine, and other drugs available with you. For sleep disturbances, this is very, very important. It must ask that how you had difficulty sleeping at night. Have you felt sleepy during the day? This is very important. You ask about, you optimize the treatment for HE, you optimize the sleep hygiene. This is very important. And referral to sleep specialists if it is there. And even mindfulness training has got root. For sexual dysfunction, this is again very important. Please do ask your patients that how have you had any sexual activity in the past few weeks. This is very important to ask. They don't tell you. You have to ask, how satisfied were you with your sexual function during the past few weeks? So the cirrhotic men, they are really don't tell you. Even the female, they have got problems there as well. So for the cirrhotic men, you can offer these drugs to these patients. The other do's and don'ts in the outdoor, the alcohol use. If your patient is alcoholic, and please do ask, alcohol is not uncommon, and you tell them that how to leave that. Liver transplant, referral is very, very important. Refer early when a patient develops decompensated cirrhosis. Please do not wait until the patient is hospitalized in life-threatening condition. Then there will be no role for the liver transplant. And for the palliative care, address goals of care and refer to palliative care early. And please wait, don't wait until the patient is in the critical state. So again, you have to be preemptive rather than reactive. What should be the do's and don'ts in the home? This is again important. For nutrition, Please do educate patients and patient's family on balanced diet, that what is the balanced diet, how they should take it. Please do not impose unhealthy restrictions. Mood changes is very important. You notice if the patient has noticed trivial memory and mood changes and several reversal of the sleep pattern, what they do, they sometimes gets confused in performing the namaz rakats, or the memories, or the in the days, or sometimes or disorientation. This is the occult hepatic encephalopathy or minimal hepatic encephalopathy, and you should be very vigilant in these. And please do not allow slipping pills, as already I've said this. For stools, please tell them that please do notice if there is any melena, because it may not be the melena is the rather frequent presentation of the upper GI bleed as that of the metamesis. And please do not allow constipation, because this will lead to the hepatic encephalopathy. For ascites, these patients should be checking the weight regularly, and they should not use the extra salt. So, my dear colleagues, to sum up the whole story, we know cirrhotic patient is a very delicate one. It's a very special population, and it's a very fragile one. And you need to give extra care to these patients. And really, a multidisciplinary team approach is required, where there is physicians, hepatologists, endoscopist has got its own role, nephrologist, sonologist, interventional radiologist, even the oncologist, cardiologist has got the role, pulmonologist has got the role, transplant surgeon, and the home nurse. So it is really multidisciplinary team efforts. At one time or another time, all these players, they come and play their role. So to the take-home points of my today's lecture is that now we know that liver cirrhosis has well-defined natural history. We must monitor cirrhotic patients over time. We must differentiate different stages of cirrhosis. We must prevent decompensation to happen. We must identify decompensation promptly, and we must link with liver transplant if needed, and we must keep patients in child class A. So with this, I'm thankful for your patient listening, and I hope that I have answered the possible questions in your mind, and I have been able to give you the overall concepts that how we can keep the cirrhotic patients alive, what are the different challenges, what are the different issues, and we shouldn't focus on only one aspect or only presenting issue. We should be treating the patient as a whole.